Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today is one of my favorite episodes. This is answering your fertility questions. Today's episode is all about natural fertility and trying to get pregnant, and I love the voicemail episodes so much. So if you'd like to call and leave a voicemail, please call at 657-229-3672, and we are working our way through them. We're about to have a whole stretch. I'm trying to group them by topic, but sometimes we'll just have some random Q&A answering sessions. The voicemail episodes are my absolute favorite because sometimes you don't even know what questions you have or you want to ask until somebody else does. So please don't hesitate. You don't have to leave your name. It can be totally anonymous. And again, that number is 657-229-3672. Before we jump into your voicemail questions, I do just want to give a quick promo to the newsletter. So the newsletter has been ramping up. We have a special Trying to Conceive freebie with some of my top tips, information on lifestyle and cycle tracking. And you can sign up for that at nataliecrawfordmd.com/newsletter. We also answer questions in the newsletter on Instagram and in our regular episodes. And you can ask those questions on Instagram every Monday at Natalie Crawford MD. All right, well, let's jump in and hear some of your voicemail questions.
Hi, Dr. Crawford. Thank you so much for all that you do for the Trying to Conceive and the infertility communities. The accessible knowledge that you share is so invaluable. So I have two questions. Number one, so my partner and I have been trying for about 6 months. I'm 30 and he's 34, so we're not super worried yet. But I do have some relevant medical history that makes me a little bit nervous. And I'm curious to see if it's anything in my story that would raise any red flags for you. So I had 2 abortions about 7 to 8 years ago when I was 22 or 23, and they were both within 3 to 4 months of each other. They were both medical abortions. On my second abortion, I had to get 2 doses of misoprostol due to there still being pregnancy tissue. I thought everything was well and good, and then about a month after the second dose, I went to the ER because of heavy vaginal bleeding. I was told that there was still retained tissue, and I still had HCG in my blood. I think I had a follow-up with an OB after that, and I think they made sure my HCG was 0 at that point, but I was so young and honestly a little bit traumatized that I don't really remember that time period much. And so my question is, can retained tissue for a few months cause any kind of endometrial or uterine lining changes that could cause any issues for future pregnancy implantation? Could this be a risk factor for ashermans? I know that DNCs are a risk factor, but I didn't have a DNC. I just had retained tissue. Could that be enough to cause any scarring or adhesions or any kind of issues to the lining? And then my question is a little bit related, but I'm having a hard time finding actual numbers for what the uterine lining thickness should be throughout your cycle. So my uterine lining was measuring about 5.3 millimeters 6 days prior to ovulation. And I always hear that 7 to 8 millimeters is ideal for pregnancy. And I know I wasn't near ovulation, so I don't know if it's okay to be a little bit thinner at that point, but is 5.3 too thin, and could that be a sign of scarring or ashermans or any kind of abnormalities in the uterine lining? Thank you so much. I appreciate you.
These are questions that many people have that are not talked about very often. Number one, and in general, having a prior abortion or 2 prior abortions does not increase the rate that you're going to have infertility. Now, medical versus surgical, there are risks with each, and one is not necessarily better than the other. The question of, does having retained products of conception increase my risk for ashermans or other issues? Ashermans is a scarring of the uterine lining, most notably associated with DNCs, especially under urgent or emergent situations, such as heavy bleeding, postpartum retained placenta, postpartum bleeding, or uterine infection. In the setting of a D&C for just a miscarriage or for a termination of a pregnancy, it is unlikely to get scarring in that incidence. Now, one of the risks with medical abortion treatment is that you might not have complete emptying of the uterus. Having retained products of conception or placental tissue still active in the uterus for a prolonged period of time absolutely can cause issues. What we're most worried about is that it can cause scarring and it can cause infection. And often these might even go hand in hand. Ultimately, it sounds like this was resolved relatively soon, had heavy bleeding a month after, went to the ER, did not end up needing a surgical treatment. And I'm going to presume since then, you've had periods over the past 6 to 7 years. One of the worst signs for ashermans is actually amenorrhea, absence of periods, or having much lighter, very different periods than you had in the past. So if you are still having regular cyclic periods, I am more reassured about the circumstance. But yes, a retained piece of placenta can cause some scarring in the uterus. And if you have scarring, even if it's not complete, that itself can impact implantation. This is ultimately really easily checked with a fertility clinic or a test your OBGYN can order. We have to look at the inside of the uterine cavity, so an ultrasound alone is not answering the question. We will need either a saline sonogram, which is an ultrasound where we also put saline or water into the uterine cavity, or we will need an HSG, a hysterosalpingogram, an X-ray dye test, where dye is placed in the cavity and X-rays are taken. Both of these tests will show us the inside of the uterine cavity, and if there is scar tissue, we will be made aware of it. A more definitive test that can also fix this is hysteroscopy, which is a surgical evaluation, and that's how you fix scarring. You go in with surgery, you cut it out, and you might need some specific post-operative care or hormones to prevent it from coming back. But often somebody's going to want to do a diagnostic test before we go and sign up for surgery. As far as the second part of the question, your uterine lining, honestly, 6 days plus before ovulation, having a lining of 5 or 6 is really great. Remember that as you get closer to ovulation, the egg is making more estrogen, and that estrogen is what is really growing the lining. So 5 to 7 days prior to ovulation, many people are going to have a lining even thinner than this and be perfectly normal at the time of ovulation. All of the uterine lining measurements that you hear about are measurements that are taken or checked around the mid-cycle, so right around that time of ovulation. So if it is something you're concerned about, you could talk to your OB about being seen closer to that ovulatory day. Yes, if you have ashermans or even partial scar tissue, we expect you will see a thinner lining than somebody who doesn't, but all the time I tell people, linings, who knows what so many women have out in the wild when pregnancies are happening and we're not monitoring. And many people just have a thinner lining, and it's not because of ashermans or prior intervention or contraception or termination or D&C or anything. It's just what their body makes. So ultimately, based on this story, 5 or 6 days prior to ovulation with your uterine lining, I'm not worried about it. If you're having regular periods, very reassuring. If you are concerned based on your history, you can always ask for a saline sonogram or an HSG, which is that dye test, to see the inside of the uterine cavity. Wishing you all the best. All right, and now we're moving on to our next question.
Hi, Dr. Crawford. I just listened to your episode on reproductive hormones, and I just wanted to clarify, can a luteal phase defect lead to what's known as chemical pregnancy or pregnancy loss between weeks 4 and 5, or would the embryo just not even implant if you truly had luteal phase defect? I've had 2 early pregnancy losses last year, and then began taking progesterone supplements, 200 milligrams twice a day, and maintained my next pregnancy for about 8.5 weeks, although it ended due to triploidy. And I'm just wondering if progesterone, which I know is controversial, could be that fix for a supposed luteal phase defect, or if, those first 2 pregnancies wouldn't have implanted or even made it, to week 5, if I truly didn't have enough progesterone naturally. Thanks so much.
Lovely and really well thought out question. I'm going to start by saying I'm so sorry for your loss. I've been there and I completely understand the desire to try to understand everything you can about what's going on because ultimately it is just so hard and frustrating. When it comes to luteal phase defect, in general, I always describe this as being the first phase of ovulatory dysfunction, meaning if we can imagine that we progress through a certain pattern, and this pattern is going to be first, normal regular periods, second, a shortened cycle or a luteal phase defect, so a short luteal phase, spotting in the luteal phase. Then you're going to have longer cycles, irregular cycles, skipping months, and eventually into amenorrhea. That is the ovulatory spectrum. So in my opinion, luteal phase defect is that first sign of ovulatory dysfunction, and there's a few different reasons why. One of the top reasons, in my opinion, is something called hypothalamic dysfunction, meaning your brain and your ovaries, they're talking, they're communicating, but they're not communicating well. We're not fully in sync, and probably because the brain is getting some interference. What's causing that interference? There's a lot of different thoughts. Inflammation, autoimmune disease, stress, not getting enough sleep, toxins, being overweight. There's a variety of potential things which could do this. But the brain is having static. It can't interpret signals to the best. Therefore, it's not sending out signals to its best. And even though you're ovulating and you can detect ovulation, the luteal phase of that second half of the cycle all is dependent upon production of progesterone from the follicle that ovulated. So there's two important pieces. If you don't ovulate a good follicle, you don't have a good base, a good foundation to make progesterone, and the brain needs to be intact and communicating to tell that follicle to make progesterone. Of course, when it comes to pregnancy loss, progesterone and loss are a chicken and egg hypothesis. Progesterone is essential for implantation. It opens and closes the implantation window. Progesterone is made from the corpus luteum on the ovary. However, as soon as that pregnancy comes, progesterone is now being made still from the corpus luteum, but not from a brain stimulus, from the pregnancy stimulus, meaning HCG levels, that what you test in a pregnancy test, should rise at a constant and increasing fashion, therefore telling your body, we're going to make more and more progesterone, ramping it up. When that doesn't happen, because potentially the pregnancy is genetically abnormal, something's not dividing right, then the pregnancy is not making as much HCG, therefore there's not as much stimulus for progesterone, and the body senses that drop in progesterone as a signal to have the miscarriage. So we often see low progesterone associated with pregnancy loss, but that doesn't always mean that the progesterone caused the loss. A lot of times it can be embryonic factors. However, I just said, having a luteal phase defect is a sign of ovulatory dysfunction, and low progesterone might be associated with that. And we know for a fact that if you don't have enough progesterone, or you have too much or too little, that impacts implantation and pregnancy. Progesterone is so essential. So I think two things can be true here at once. I do believe that if we are talking about potential pregnancy loss from progesterone, that it is going to impact the implantation process. So yes, that would more likely appear as a chemical pregnancy or a positive pregnancy test in week 4 or 5, and then it goes away and you start bleeding, as compared to getting further along and having a fetus develop that stops growing, having a genetic abnormality. That's a completely different scenario. This is why it's not wrong to give somebody progesterone, but a lot of times, if you're going to do it, the time where you can have the most impact is to give it after ovulation and not wait till that positive pregnancy test, because that's late. Many of us actually like to treat the ovulatory dysfunction, and that is often treatment with maybe Clomid or Letrozole, medications for an attempt to try to make you ovulate a better follicle. And sometimes just ovulating a better follicle will result in having more progesterone produced. I often add progesterone after ovulation in addition to ovinduction, but that's probably overkill. I'm just a little bit controlling. But to answer the question, my concern with chemical losses is going to be Number one, increase in genetic abnormalities. Number two, implantation issue. One of those is a potential ovulatory issue or luteal phase issue. All right, before we go to our next question, I just want to remind you that if you'd like to call and leave your voicemail, that number is 657 229 3672. Again, 657 229 3672.
Hi, Dr. Crawford. My name is Katie, and I just wanted to say thank you so much for all of your amazing content. It has helped me learn about myself and my body so much. I had a question as it refers to luteal phase defects, possibly, or spotting. I am 37 years old, a mom of 4, and I have spotting pretty regularly before my period. I don't want any more children, so we are tracking my period, and I was wondering for tracking purposes if I should begin counting my cycle day 1 on the first day that I see spotting or the first day that my flow regulates into a more normal flow. Again, thank you so much for all you do, and I look forward to tuning in to see if my question gets answered. Thanks so much.
Hi, Katie. Thank you so much for all of your kind words. It means so much that you took the time to call and ask this question. So there's a couple different components to think about. Number one, spotting. Is it normal? Can we just say this is ovulatory dysfunction? It needs an evaluation. I know you don't want to be pregnant, but what all can cause spotting? Certainly having some hormonal issues can, so that can be having an egg count that is lower, having ovulatory issues, thyroid abnormalities, prolactin abnormalities, but it also could be due to a polyp or a fibroid in the uterus, or even potentially having abnormal pap smear, cervical dysplasia, abnormal cervical cells. So when we do have some abnormal spotting, sometimes we see it consistently in a phase of our cycle just because of what the lining is like. So often I'll see people who have a polyp, for example, have spotting in the luteal phase. And that is just because of the lining is compacting, exposing that polyp and allowing some spotting to come out. Now, most polyps are benign projections of the same type of tissue that the endometrium is, just in a more polypoid form, so a little ball almost inside the uterus, and they're very benign. However, sometimes polyps could be cancerous, and removing it could take the spotting away and just make life simpler. So a visit to an OBGYN to evaluate your mid-cycle spotting and make sure you don't have a polyp is something I would recommend you do. To answer your question better, is the bleeding, the spotting the first day, or is it the first day of full flow? I always say it's the first day of full flow, especially in this scenario. If you want to know for sure, am I actually having a lot of days of spotting before I bleed? Is that my follicular phase or my luteal? Remember that onset of menses, onset of that period, comes approximately 2 weeks after you ovulate. And you don't need to ovulate or track your ovulation every single month, but you could for 1 month and confirm what we're thinking, especially if you want to use those cycles as a way to naturally try to prevent a pregnancy, right? Avoid your fertile days. You don't want another kid, but you don't want to be on hormones. So what I would recommend you do for 1 month is start taking an ovulation predictor test. You would want to take this a few days before you think you ovulate. So if your cycles are on average every 4 weeks, I usually say start taking an ovulation test around day 10. These are urinary-based tests where you will urinate on the stick 1 time per day, and I recommend that you are actually using the test between 10 a.m. and 2 p.m. I know what the box says, but because we need to give the hormone time to get from your brain through your kidneys, your bloodstream, and into your urine, I want you to check a little bit later. Once you get a positive, you don't need to keep testing because the hormone you're checking is LH, and it's going to rise and fall the whole luteal phase. So let's not go down this avenue of checking it over and over. But once you check it and you get a positive, then you're going to know that you're going to ovulate the next day. If your period, the full flow, comes 2 weeks after that, then you're correct. All of your bleeding spotting is in fact luteal, and your period is coming, your day 1 is when you have the full flow. If the spotting happens 2 weeks after that positive test, then that's actually your day 1. Understanding your own cycle is really important, especially if you're trying to use that cycle for tracking either to get or to prevent a pregnancy.
Hi, I would love an in-depth episode or section of an episode where you talk about the percentage, I guess the chance or the probability of getting pregnant if you are having sex at the right time and you're ovulating, kind of either with or without fertility issues. I've read online that it's about a 20 to 25% chance, but then I've also seen people talking about how those numbers are from a very old study and they're very different in the way they kind of group people together, like it's not a very controlled study. And obviously you've talked about this and studied this really in depth, I think. So I would love to hear your opinion on it. If somebody does the deed at the right time, all factors given, what does that probability look like, maybe by age group or however you decide to break it up. Anyways, thank you.
I love this because one of my passions and very large research interests has always been on what we call fecundability, which is the probability of getting pregnant naturally, so without fertility intervention. You are absolutely correct that original studies that told us the fecundability rates for groups of populations typically used a fertile population who had children and then asked them to recall how long it took them to get pregnant. That was how we judged natural fertility rates. Well, obviously there is bias because number one, where is the infertility reflected? What about all the people who didn't conceive? They are out of the group altogether. And what about maybe you don't remember or you're looking through rose-colored glasses? So truly one of the best, more modern analysis we have on this is work done by Ann Steiner, who is an REI, and she was my fellowship mentor. She had a large preconception cohort called Time to Conceive. And this was a group of women who were actively trying to get pregnant, who did not have infertility. Some of them have had a child and some of them have not. So we have numbers for both groups. And they were having sex, they were tracking ovulation. And a lot of the data from the cycle is excluded if their period length was really long, they weren't ovulating, or if they didn't have sex. So there was no intervention in this study. It wasn't take these vitamins or use this ovulation tracker, but the women were given ovulation trackers. They did have to have a diary per se of when they had intercourse, when they had bleeding, and no other intervention was done. It was just watching them, but did give them some tools in order to adequately collect the data so that you could exclude people, to your point, who weren't actually trying, because that's going to take the data away. The point of the study was to look at an older group of women. So this study looked at people who were 30 and older, and the study compared them to the age-related rate of getting pregnant if you're under age 30, which is about 25% per month. So even at your youngest, most fertile, you're not going to have more than a 25% chance per month of getting pregnant. Remember, human reproduction is very inefficient. When it comes to the study, people were divided into if you had never had a child before or if you did have a child before, and then age groups were evaluated, and you're going to see some of the difference. So if you have not had a child and now you're 30, you're trying to get pregnant, between 30 to 33, your chance is going to be about 17 to 19% per month. So that's quite a drop, especially as compared to 25% that somebody might have at age 29. Now, if you are trying for your first child, you're 38, 39, 5% per month, and if you're 40 and above, 3% per month. If you've had a child before, these numbers don't look as scary. So if you have had a child, now you're trying to have a second, third, future child, you have a 22 to 23% chance per month of getting pregnant between 30 to 35. So you have a little bit higher rate than your age-related peers who have no child. And why is this? Honestly, it's because certain things have been proven. There was obviously sperm. You had a child, so implantation could happen. A tube was open. So you already have what we consider to be proven fertility, and it puts you in a different risk group. We still see a drop with age. So 36 to 39, we're now looking at 15, 16%. At 40, about 10%. And as we get older than 42, it still is going to drop. So it gets harder, no matter if you have sex at the right time. But what we are most concerned about is people who are waiting to start their family, having these lower percentages of getting pregnant per month, delaying a diagnosis of infertility, having something wrong with them, and not able to intervene until a much older age. So knowing that you have an issue or could need help at an earlier age is going to greatly change the trajectory of your fertility journey.
Hi, Dr. Crawford. Thank you for taking my question and for all your podcasts and YouTube videos. They have all been very informative. My question today is about cervical mucus. My husband and I are planning on trying early next year for a baby, and as I'm learning more about fertility and my body, everything about my cycle seems very normal and predictable. I have a regular period, OPKs look good. I can even feel myself ovulate mid-month, like 2 weeks before my period starts. However, I noticed that my cervical mucus doesn't really line up with what I've been learning that I'm supposed to be seeing. I never get that stretchy egg white cervical mucus. It's more just watery with kind of tiny balls of discharge that stretch very little. This is the only thing that's worrying me when it comes to my fertility. I'm wondering if this is normal and if you see women struggle to get pregnant when their cervical mucus isn't textbooked, so to say. And if you think this may be an issue, is there anything I can do to increase that fertile cervical mucus? For context, I did start taking prenatal vitamins about 2 months ago now, and I am also 31 years old. Thank you so much.
Really nice question that leads to what's the most important method of tracking your cycle and what does this really mean? Now, when it comes to your period tracking, it sounds like you even have middle schmerz. You can feel when you ovulate, regular cycles. Otherwise, everything is really on track. And that ultimately is what you're going to go by and is very, very reassuring. Cervical mucus is made by estrogen. So as you're getting closer to that mature follicle, your estrogen will get higher, and that's going to make the cervical mucus. Many things can impact the cervical mucus, and studies have disproven the utility of testing it. For a little history lesson, back in the day, there used to be a test where you would evaluate somebody's cervical mucus after they had intercourse and see how the sperm moved through it. Was it stretchy enough to let the sperm go through? But that test hasn't shown to be helpful in actually helping people get pregnant. And there's a lot of variety in cervical mucus, and what I see is a lot of the medications we take, a lot of it's about your hydration status. Many people who've had surgeries on their cervix, maybe an abnormal pap smear, had a leap or a cone, are never going to produce the exact same cervical mucus anymore. And so there's a lot of variety here. Medications that can cause abnormal cervical mucus, antihistamines, allergy medication, everybody in Austin's on those, antidepressants, some sleep medication, cough suppressants, cold and sinus medications, fertility medications, even Clomid can change your cervical mucus. We also can see that sometimes having just less bodily estrogen, like being thinner, potentially if you are douching, doing any vaginal cleaning, if you have any vaginal infections, all of that can change the cervical mucus. So there is a lot that does contribute, making it the least reliable if you have all of the other factors that can be very good. Yes, can cervical mucus, if it's abnormal, impact your fertility? Only if it's caused by something else, that is, if that makes sense. Meaning, if your cervical mucus is abnormal because you have a cervical infection, that definitely might cause a lot of inflammation and impair your fertility. But if your cervical mucus, you're just never getting that type 4, sounds like you're staying at type 3, that just might be what your body can make in context of maybe medications you are on, how much you're sleeping, and if you're still ovulating, you're making enough estrogen that I wouldn't worry about it. You don't need cervical mucus like lubrication for sperm. It is supposed to help the sperm, that it thins out to help the sperm get through the cervix. So one thing that I see people do wrong is think that I don't have enough cervical mucus, so I'm going to use extra lubricant. That is not recommended and definitely not something that you need to do. Ultimately, if somebody has abnormal cervical mucus or they never get the type 4 and they're having a difficult time knowing when they ovulate, I'm more concerned that there might be something hormonal going on or something that we should do. In this case, it sounds like you can track cycles. I'd be interested to know the medications you're on and some more about your health history, because I bet the answer lies in there. Ultimately, wishing you all the best and hope you conceive soon. Thank you guys so much for calling and leaving all of your questions. I love them so much. Can't wait to do more episodes. The number you can call is 657-229-3672. Remember, you can also ask questions on Monday on Instagram at nataliecrawfordmd. Some of those questions will be answered on Instagram, some on the podcast episodes, and some on the newsletter. The newsletter has a lot of great tips, tricks, Q&A, fertility in the news, my favorite recipes, and ultimately just a way to stay in the loop with everything that's going on. As the book is being written and coming out, there's going to be so many new and exciting things. And I do have the TTC Starter Guide, which has a lot of lifestyle and cycle tracking information if you sign up for the newsletter. So you'll find that at nataliecrawfordmd.com/newsletter. And also on the website, you can learn about our fertility courses. The Enhance Your Natural Fertility is the signature lifestyle course, which comes with a Facebook group, lots of great handouts, and great modules that you can learn at your own pace. If you're going through IVF, there's the add-on IVF guide, and I recommend getting both so that you can really have all the lifestyle information, but deep dive into IVF protocols and how you optimize your care for success. Ultimately, keep asking your questions, 657-229-3672, and thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.